Assalamu alaikum warahmatullah. In the last week, we had presentations on multiple injuries and practical sessions, and today we'll go through penetrating abdominal trauma. We will concentrate on the clinical decision making and the high yield protocols using the last versions of ATLS manual, the 10th and the 11th editions. At the beginning, we remember from our anatomical knowledge the areas of the abdomen and chest. We have the thoracoabdominal area, and or generally we distribute it into the anterior abdomen and the including the thoracoabdominal area and the pelvis. We have the flanks, and then we have the back, which includes the retroperitoneal organs. And so we can now imagine if a penetrating subject is entering through any one of these anatomical positions, we will remember the anatomy and the organs inside which can be injured. For example, in the thoracoabdominal area, we have the chest, we have hemothorax, pneumothorax, we have underneath the liver, the spleen, and others. And in the retroperitoneum, there are the organs like the kidneys, the pancreas, and the ascending and descending colon, and so on. So the anatomy or the baseline knowledge of anatomy is very important in abdominal trauma. We have knives on stab wounds and gunshot wounds, and they are different from each other. And the most important factor here is deciding the difference in the injury is the velocity. And this is a physical equation. The kinetic energy equal half the mass multiplied by v times 2, where v is the velocity. So if we have a high velocity, we'll have more injuries. Like this bullet traversing, there is a surrounding wave of injury to the organs, and sometimes even causing burn to the surrounding organs, unlike the knife or the stab wound, which will cause injury by direct slicing and injuring the organs. Blast injuries is a multi-dimensional assault. يعني يمكن بالعربي if there is a blast injury there is a wave surrounding يعني من الانجري، بعد ذاك في الشرابنرز أو الشظايا اللي بتصيب المريض، والإصابة المباشرة by blunt trauma or the impact, and it can be completed by associated injuries like burn, chemicals, and other injuries. We start our initial assessment by the ABCDE or the X ABCDE, and we speak about this opening the airway, breathing, circulation, and until we do exposure and environmental control. In the diagnostic adjuncts, or actually before the diagnostic adjuncts, while doing the ABC, remember the important things. For example, when exposing the patient, you look for signs in the abdomen, and starting with the hemodynamic status of the patient in the ABC order. In the abdomen, you look for wounds, you look for evisceration, which is a viscera or organ coming out, and other like distensions and these things. And even here, we remember the sample or ampule histories that we described before. Here, we ask a specific question regarding abdominal injuries. Then the next step, the diagnostic adjuncts or diagnostic triage matrix. We have three main components, which are the ultrasound, the DBL or diagnostic peritoneal lavage, and the CT. And here are the differences listed in the table regarding the indication, advantage, and disadvantage. For example, ultrasound we can use in hemodynamically abnormal or normal patient. It is very rapid, and it can give you immediate result. It can be performed even in the resuscitation bay, but it is an operator dependent procedure. So if you are expert, you have courses, you have seen many patients, you can diagnose correctly. And as we mentioned before, the early diagnosis is very important to save the patient. DBL can be done in unstable patient. And very important, DBL, we use it if the patient is unstable, we cannot push him to CT scan, and the ultrasound is equivocal. Here you need another adjunct to clear out the patient. DBL is highly mandatory or indicated in this patient. It is highly sensitive for blood and products like bowel material or bowel injury. However, it is invasive procedure and required interpretation in the labs. CT, the main indication, it is indicated in retroperitoneal organs because they are not assessed well by ultrasound and DBL. However, the disadvantage, it cannot be done in unstable patient because it requires transport, and it has advantage of detailed or detailing the injuries, for example, grading organ injuries. We have to be aware about negative ultrasound or negative fast, especially in penetrating trauma like this picture you see. You can have a bullet passing through causing a small injury in bowel or stomach with a small leak, and the patient will find just mild tenderness, and he mentions mild pain. However, the critical signs, the peritonitis and other things, they appear later, and initially even the ultrasound can be negative. So follow up by vital signs, clinical signs, and follow up radiology by doing ultrasound is very important in this patient, or sometimes you need to push them for CT if they are hemodynamically stable. Red flags are important to be stated, which are the indications for immediate laparotomy. So if there is a red flag, you don't delay the patient, don't delay the procedure, don't delay the laparotomy by sending the patient to doing any other investigations. Hemodynamic instability is a strong indication for intervention. You have to do laparotomy. The mechanism, if there is a through and through bullet going, for example, from flank to flank, so definitely pass through all the organs in between, so don't delay the patient, resuscitate and push to the operating room. Clinically, if there is a visceration, as we mentioned, the viscera is coming out, or there is clear signs of peritonitis, is a strong indication to interfere and do laparotomy. And some procedural indications, like when doing DBL, find it positive particulate matter and or positive RBCL, white blood cells, are indication for intervention. Then the decision making can be graded according to the regional area. In the anterior abdominal wounds, it is mandatory when there is peritonitis or shock, so we have to do exploration. Again, in anterior abdominal wounds, selective non-operative management is protocol which can be adopted if the patient is hemodynamically stable. There are minor signs or no signs. This patient can be assessed by serial abdominal examination, doing follow-up ultrasound, and borderline patients should be followed in the ICU, and they should be back up for laparotomy at any time. Thoracoabdominal wounds, hidden threats are hidden threats. There is a high risk of ocal diaphragmatic injury. It can easily be missed, and we can imagine that in full expiration, the diaphragm can go up to the fourth intercostal space. So you can miss this diaphragmatic injury, which can cause serious sequelae immediately, and later on can cause problems. So you have to diagnose it, and sometimes even we need to go to diagnostic laparoscopy to diagnose the diaphragmatic injuries. In the retroperitoneal, this is the last one we are left with in regional decision making. Thick paraspinal muscles can make protection and even will hide you detecting the signs, and these are situated posteriorly in the abdomen. So in fast DBL are not working. CT, as we mentioned, is mandatory. It is a gold standard. We do it with either triple or double contrast, yani IV, oral, and even sometimes rectal contrast when there are some injuries. Lastly, the last two slides before the last one, there are some special situations, physiological extremes, the pediatrics, the geriatric. Pediatric patients have very strong compensatory mechanism, and hypotension usually is a grave late sign. So if you have to be aware about pediatric patients, normal blood pressure can be there, however the patient is shocked. So you have to rely on tachycardia, and you have to have a chart of assessment for these patients. The physiological reserve, even in geriatrics, sometimes they are taking some drugs, and depending on vital signs, sometimes can deceive you. And in blunt trauma, for example, there can be pre-existing condition and medication. So also we have to be aware about geriatric patients, and even pregnancy. The uterus will protect the organs. However, the uterus is prone to injury. There are some additional things we have to ask. For example, if she is having bleeding, she is having some vaginal bleeding, and assessment of the abdomen, even the clinical signs can be hindered by the gravid uterus. Last slide. This is a master algorithm, starting by X, A, B, C, D, E. So if there are red flags, you go immediately for laparotomy. And we mentioned the red flags: evisceration, hypotension, positive abdominal signs, and all these indications for immediate laparotomy. And most of the penetrating wounds. If there are no red flags, if it's negative, then you look at the hemodynamic stability. So if he's hemodynamically unstable, here, unstable, you go for FAST or DBL because you cannot do CT scan. So if you do FAST or DBL, it is positive, you go for laparotomy. If it is negative, you look for other sources like shock, like cardiac tamponade and other things. And we go back to hemodynamic stability. If the patient is stable, then the gold standard is to go for CT, as we mentioned, with either double or triple contrast. If it is positive, it will indicate laparotomy. But if it is negative, you don't discharge the patient. Still keep the patient, do conservative treatment, and you can also do other follow-up, CT or ultrasound. You can find injuries later, as we mentioned in some penetrating injuries. Thank you very much. See you later in our upcoming presentation.